At the onset, I would like to thank MedPipe Technology, JournoMed, in association with Daffodil Health from Bangalore, for hosting this program, Celebrating Autism. And the topic given to me today is reproductive health and obstetrics and gynecology healthcare in autistic adults. I think we had a rather candid, lucid presentation about the spectrum of autism. Till today, nobody knows the actual reason for autism. It's multifactorial. There's a genetic component to it. There's an environmental component to it. And increasingly, more and more individuals are diagnosed with autism. Though the prevalence is 1%, that is 100, they say it's around 1 in 68 to 1 in 70. As a healthcare professional, very often we don't come across these patients. We get referred either by a clinical psychologist or a psychiatrist. And the reason, it will most often be a child who's in the prepubescent stage, or an unwanted pregnancy, or someone who's requesting contraception. These will be the common areas when we have individuals with autism being referred to us by the psychiatrist. And I have to admit, we are literally thrown at the deep end because, as she already said, their world, their language is different from ours, and we fail to understand it because it's not inability to communicate, but we don't understand their way of communication. And then the picture, the video there showed their behavioral patterns, which we consider them as obsessive and repetitive behavior, while the individuals with autism say is a sense of perceiving the 5 senses like vision, feel, touch, etc. By and large, until the 1990s, it was generally considered that autism is only prevalent among men, among small boys, and then later on they go on to become men. But now studies have shown for every 3 to 4 male affected with autism, there is 1 female who is diagnosed with autism. One of the main problems with women suffering from autism, they are diagnosed at a very late stage, sometimes even in their 20s and 40s, because the mapping of the human brain when compared to a male and a female is different. And when it comes to social behavior, women are much more, they're better at it. They can mimic the so-called individuals who do not suffer from autism, and they can camouflage their symptoms. I'm going to this is going to be a very short speech, and I'm going to split it into 3 groups. What happens during pre-puberty and puberty, during the reproductive age group, and during menopause. As I said, there's a false perception. Individuals with autism are asexual. They lack sexual orientation. Very often caregivers, either the form of parents or who come from homes or special schools, they say, what do we do? She just started a period, or she's about to start a period. Is there any way we can suppress it? My humble request is, I think suppressing menstruation should never be on the mind for any gynecologist. Though it's an individualistic approach, it varies from patient to patient, but overall, we need to ensure the young girl gets enough estrogen to protect her skeletal system and her cardiovascular system. And for that one medical reason, I think we should not suppress menstruation completely. And it's well known, a girl, an autistic girl, as the spectrum is quite wide, and it varies from individual to individual. And it's believed A young girl who knows to use the toilet independently can easily be taught how to handle herself, manage it with pads and hygiene at the time of menses. There's another false belief that individual girls with autism do have early onset of menarche, but studies have shown it's no different. But one of the problems with these young girls is they have very irregular cycles and continuous bleeding, and that's the reason they are referred to us. One of the reasons. I think we need to look at them as when you approach a young girl who's attained menarche, it's just not about sex. I think the sexuality of the girl is very important. What I mean by sexuality is it's an overall healthy development towards sex. It is just not sex. It is the way the young girl feels about the developing body, the changes, understands feeling of intimacy, attraction, and affection for others, therefore to build a long-standing, sustained relationship, and able to maintain and respect intimate relationship. So that's sexuality. It's just not the physical component of sexuality. It is also the emotional component we need to address. And we need to take that into consideration when someone with autism is presented to us. Usually they don't come on their own. Usually it will be a reference. They'll come with their primary caregivers. And we need to look at the picture holistically. So what do you do to these kids? Most of them, it depends the spectrum. They may go to special schools. So we need to educate them, sex education, the importance of condom, to educate about the importance of menstrual hygiene. Studies suggest that 15 to 35% of individuals with autism suffer from are homosexual, have homosexual or bisexual orientation. Sorry, I excuse the word suffer. But the reason for delay in diagnosis in autism among women, as I said, they are very good at camouflaging their symptoms. When they get into an intense relationship, then they have problems. They're not able to sustain the relationship. They're not able to understand, as she explained, their sensory stimuli is very different from ours. It's believed they have a poorer level of sexual function, and they find sexual relationship very unpleasant, more than boys affected with autism. And very often, another reason could be they are victim of sexual abuse or assault. But sex education is very important, and we need to emphasize on these children so that they do not develop other kind of sexual behaviors like hypersexuality, paraphilia, or sexual offenders. This is one side to the problem. The other side is prevention of sexually transmitted disease. You should emphasize the importance of condom and the importance of, if that individual is able to have a child in the future, the level of the learning disability or the intellectual capacity should be known. Very often, we dissuade the caregivers not to allow suppression of menstruation. Let the child experience menarche, let her have her periods. And later on, if the child is not able to handle a monthly periods, then we need to look at methods of suppressing menstruation at the same time acting as a contraceptive too. The most commonly used is Depo-Provera. Some of them use continuous combined oral contraceptive pills for about 12 weeks, and then they have a breakthrough bleeding. Progesterone-only pills, GnRH analogs, and levonorgestrel intrauterine device. But all these medications have problems, especially the progesterone derivatives like the Depo-Provera, the POP, and the levonorgestrel device. They decrease the bone marrow density and increase the patient's weight, the individual's weight. And the combined oral contraceptive, as you know, it increases the risk of thromboembolism, increase the risk of carcinoma cervix and carcinoma breast. There's a wrong assumption that premenstrual tension or premenstrual syndrome is much higher in girls suffering from autism. It is no different from girls not without autism. So we need to look at all these issues and protect if you think that person cannot become pregnant and they need some kind of contraception, then these are the ways to address the issue. But once again, when you're inserting an intrauterine device, who's going to give consent for these children? So in UK, you need to get a high court order before you insert the device. I come to the reproductive age group. Can individuals with autism have children? Can they become a parent? It is yes and no, once again, depending on the spectrum. The first question they ask individuals with mild autism who have the capability of understanding better than the severe on the deeper end, will my child have this experience autism or will have the same problem as I have or my husband has? And you have to come out with an answer. I don't know, but the chances are high. Very often, it is multifactorial, and we are not able to do any prenatal diagnostic test like how we do for Down syndrome, because it's multifactorial and there are about 100 to 200 variant of genetic mutation. And so we can't pinpoint and find out what actually causes autism. So we need to explain that, but then we have to tell the parents that the chances, because many studies have proved that it can be passed on to the child, especially when both the parents are affected, the chances are more. And when the age of the father is higher, then the chances are more for the child to acquire autism as soon as as time goes by. Now, when there's a family history of autism, autistic single or both parents, then they are at risk. And when they're more than 35, I said, older the parents, more the high risk of autism. And it's also believed that it's not necessary that even non-autistic parents, they have a risk of having children with autism in the future because the mutation keeps changing constantly. And what are the complications for these women in case they become pregnant? Main thing is, as she said, the sensory processing becomes very difficult for them. They are not able to adapt to the changes that occur during pregnancy, especially during the first trimester and last trimester. The physiological changes are intense, like the hyperacusis to smell, like nausea, vomiting, early morning sickness, and back pain. And the alteration, the shape of the body can be extremely disturbing for these patients. So we need to look at that and counsel them adequately. And most of these women, if they develop early onset gestational diabetes within 26 weeks of the pregnancy, the risk of them having an autistic child is for every 1,000 gestational diabetic patient, autistic gestational diabetic, 7 of them have a risk of having an autistic child. And for medical reasons, you have to terminate the pregnancy. So preterm labor is very common. There's elective section. And if an autistic individual is going to start her pregnancy being very obese, then there's a risk of preeclampsia and its associated problems. And if they're anemic, again, it increases the risk of their babies having autism. So we need to explain all these issues to the primary caregiver and to the individual, the autistic individual, or the parents who want to become parents. Should we continue? Most of them are on anti-epileptic drugs or psychotropic drugs, because especially women, as they go apart from autism, they develop comorbidities, especially psychiatric comorbidities like depression, bipolar disorder, and then they need medication. Should we stop this medication? No, especially anti-epileptics. It is a big no, because the incidence of epilepsy increases during pregnancy. And if we stop the medication, we'll be harming the child, because epilepsy by itself produces hypoxia, which can affect the baby significantly. So we should not stop anti-epileptic drugs, and we need to continue the medication as and when planned. And these are the do's and don'ts when an autistic individual is prepared for a pregnancy. But we need to understand most of the autistic couples or one person is who's affected by autism, they do have difficulty in their relationship, and the incidence of breakup in their relationship is very much high. The incidence of premenstrual tension among autistic and non-autistic individuals is not very high. It's the same. But when it comes to menopausal symptom, the age of onset of menopause is same, but the symptoms like hot flushes, night sweats are much higher in individuals suffering who have autism than without autism. And we need to make sure they get adequate calcium supplements, and if required, go on hormone replacement therapy in the long term. The other major question when parents come with these young girls and their anxiety is, what do I do with my daughter or my son once we are gone? And it's a very challenging question, and we need to address those issues as well, though it may sound very crude, but we need to be realistic. Studies suggest that in autism spectrum disorders, individuals with learning disability and neurological conditions, their lifespan is only around 39.5 years. That is, they are more likely to die. The average lifespan all over the world is 70, but these people are more likely to die about 30 years earlier. And autism without learning difficulties, even their lifespan is shortened, and their average lifespan is about 56 years. And the reason for individuals without learning disability but are autistic is because they are at a high risk of suicide. They are 9 times more likely to harm themselves than non-autistic individuals. And especially the suicidal tendency is higher among girls with milder form of autism and not the other end. So by and large, it is very poorly understood phenomenon, as Ms. Rakshita rightly said. You know, in fact, I wanted to round up my speech with empathy, and that's the exact word she used as well. Because it's not a visible disability, as she rightly explained. And very often, when the child has a different form of behavior, the society kind of either blames the parent or blames the child for improper upbringing, mainly because of lack of awareness. And especially when it's on the milder side, it's very difficult for parents to come to terms why the child is experiencing these kind of episodes, which was explained in the earlier speech. So I think the need of the hour is increase in awareness. For that, we had to have sustained educational programs, just not as much more importantly for healthcare professionals, for specialists, how to deal with these patients when they attend our office for consultation. And in the long term, these individuals, their primary care physician and primary care givers, there should be a consistent face, a dependable face, where the autistic individuals don't feel insecure. And they have to be in touch with the social worker and special therapists. But we need more research on autism. It's going to take a while. But as Rakshita earlier said, that most people, they don't want to accept this as a disability. But when it comes to the moderate to severe spectrum, they do have problems in handling themselves. And then you need to put them under the disability group. So individuals with autism do come back. In India in 2017, the Persons with Disability Act, they included individuals suffering with autism as well, because this will help us to help them get help from the government socially and economically. There are methods now. There are a lot of research going on how to diagnose autism and start early intervention. And there are special ophthalmological instruments where when they see how the child makes, where they watch child's eye movement during a nursery rhyme or a specific music, and then they kind of predict whether this child is at risk of developing autism. So the most important thing is early diagnosis, early intervention, and treat them with empathy. And I think each and every individual who has autism you can't kind of, as a gynecologist, we have protocol driven treatment. As cardiologists, we have protocol driven treatment. For most of us who do clinical medicine, we have protocol driven practice. But in autism, we cannot have a protocol because each and every individual is different. As I said, it's a spectrum. So we need to address that issue. And when these young girls or women of middle age or older women, when they come to your clinic, I think we need to understand, spend more time, give them a longer period of consultation, talk to them more, consult with your stakeholders, other stakeholders, because it has to be a multidisciplinary approach to get a better outcome. Thank you very much.